Hello there, I'm Tony Meekum. Today's topic is location-specific pathology. So get your study guide out and your chart handy. This topic is organized a bit differently from the others. So rather than sorting lesions by how they look, we're just sorting them by where they live, because for this particular group, location alone gets you most of the way to the diagnosis. Each of these has a home address, and once you know the address, the differential narrows dramatically. So first we'll cover the Nasopalatine duct cyst in the anterior midline, then the Stafne defect in the posterior mandible below the canal, the lateral periodontal cyst alongside a vital root, usually of a mandibular premolar, the benign neural tumors within the mandibular canal, Buccal Bifurcation cyst at the furcation of a mandibular molar, and then we'll finish with soft tissue developmental cysts. So 6 locations, 6 answers. Let's get going. All right, so the Nasopalatine duct cyst, also called the Nasopalatine canal cyst or incisive canal cyst, median palatine canal. This arises from remnants of the nasopalatine duct along with nerves and vessels that proliferate and undergo cystic degeneration. Age range is broad, so most are discovered in the 4th through the 6th decades. There's a notable male predilection, roughly 3-to-1. Clinically, you might see swelling just posterior from the incisive papilla. Most are asymptomatic, although patients can report a burning or numbness over the palatal mucosa as it starts to interact with the nerve that exits right there. And if it does drain, it'll taste salty. As far as imaging features, location, location, location. So remember that. This is the whole point of the topic. It sits there in the nasopalatine canal. It may extend posteriorly into the hard palate or anteriorly between the incisors, where it can expand and destroy the buccal cortex. Its shape and periphery usually well defined, circular to oval. When the anterior nasal spine superimposes over it, you get the classic heart shape of one of these. The internal structure is typical of a cyst. As for effects on adjacent structures, look for divergence of the roots, the central incisors, occasional root resorption, expansion of the labial cortex, and superior displacement of the floor of the nasal fossa. So here we have 2 examples of a nasopalatine duct cyst. Note the very cyst-like, very well-defined, corticated, smooth borders. And then I want to point out one very important thing. On all of these, no matter how big it gets, look at the PDL space. That remains intact and continuous. That's one hint that this isn't a periapical lesion, because in most cases you see a radiolucency of the apex, and that can progress into a larger lesion, potentially a periapical cyst. And keep that in mind, that differentiates periapical cysts from a lot of these other things that we've talked about, OKC, amyloblastoma, lateral periodontal cyst. Here it is on a CT, so axial and coronal CT of nasopalatine cyst. It's sitting palatal to both the maxillary and central incisors. In this case, it doesn't look that corticated, but that's why I say never diagnose from just one slice. You look in a different slice, and it definitely looks well-defined and corticated. And this is a huge cyst, taken from 2 different perspectives. Your standard occlusal view, look at the well-defined smooth borders. And then this lateral view is taken by placing the receptor outside the mouth against the cheek and directing them being tangentially across the surface. And so 2 different angles gives you a different story, but in some cases is one of the most useful things you can do to localize a lesion. Look how expansile this is. Then the nasal cavity gets pressed up like this. The hard palate line gets depressed inferiorly, but it maintains that nice cortical outline, really telling you that this is a well-behaving corticated benign lesion. It also shows a cortex from the periosteal reaction here. This is the differential, and this is the practical question you're going to actually face. Is this a cyst or simply a large incisive foramen? Look for the expansion characteristics of a cyst and use sequential radiographs to look for changes over time. On the size threshold, the oral pathology literature often cites 6 millimeters as the upper limit, while radiology literature says 10. In my experience, having looked at many thousands of variants of the nasopalatine foramen, 10 millimeters matches reality better. So honestly, it might be even larger than that in some cases that I've seen. So don't diagnose a cyst based on size alone. Also consider radicular cyst, and we told you how to distinguish that by the absence of the lamina dura, the PDL space. What else can you do clinically? You can do a vitality test. You can also do a slob rule to determine the true location. Management is pretty simple, as you would expect for a true cyst, just enucleation, with marsupialization, which could be considered for large cysts. All right, now this is an axial CBCT of an asymmetric incisive canal. Notice how it's continuous with the nasopalatine canal, with the incisive canal. It looks like something emerged from there. Now I've seen a lot of variations of this, including like this, where it abuts the palatal aspect of the teeth, and it turned out still not to be a cyst. So sometimes it'll surprise you. There's a lot of variation in this. This is wide enough that I'd start suspecting it though, especially if you start to get symptoms, you start to get expansion on that part of the hard palate. Here's a thought question for you. How do you differentiate the nasopalatine duct cyst from variation in the nasopalatine duct? And so I mentioned size greater than about 1 centimeter, also expansion, but expansion is more reliable. If you see this changing over time, and especially you start to sense expansion clinically, or the patient does, that's a good sign that you have a cyst growing there. And now we have median palatal cyst. This is a rare lesion that theoretically develops from epithelium entrapped along the embryonic line of fusion of the lateral palatal cells. Some people think of this as just a variant of the Nasopalatine duct cyst, which is further back. It is just a developmental thing. So either way, treatment is going to be the same, and it's going to behave just like a cyst, like you would expect. Clinically, there can be a firm or a fluctuant swelling in the midline of the hard palate, usually in young adults. This one's an important one, the salivary gland defect, or the Stafne defect, sometimes called lingual salivary gland depression, developmental salivary gland defect, Stafne bone cyst, static bone cavity, a lot of different terms. I don't use all of them, but you've got to be familiar with a couple of them, probably the most common, Stafne defect, salivary gland depression. The mechanism is a depression in the lingual surface of the mandible created by growth of an adjacent salivary gland, usually the submandibular, but sometimes it happens in the sublingual and then rarely in the parotid. It may continue to grow slowly. It appears roughly 1 to 5 per 1,000 panoramic radiographs, so you'll probably see one throughout your career. Shows a strong male predilection at about 6 to 1 and presents in about the 5th and 6th decades. It's worth noting, although we call it developmental, it doesn't appear to be present at birth, which is why you see it in middle-aged or older adults rather than children. As far as imaging, this is the highest yield location in the entire topic. You got to recognize these. A well-defined, corticated, round to ovoid, occasionally lobulated radiolucency. 1 to 3 centimeters, sitting in the posterior mandible. And then I'll particularly point out these areas where it's below the canal, because that means what? It's not odontogenic. So don't start thinking odontogenic keratocyst, amyloblastoma. Most of these things we've talked about in this course are odontogenic. This is the one thing, and fibrous dysplasia, but this looks nothing like fibrous dysplasia, but this is the one thing so far we've talked about below the canal. I guess dense bone islands, those can occur anywhere. What else is non-odontogenic? Traumatic bone cyst, that's one that could occur anywhere, although it typically does occur more in the odontogenic region. And then also focal osteoporotic bone marrow defect is another, a lot of times non-odontogenic one, but one of the common findings for those is an extraction site that just didn't heal in. And so that can have a tendency toward odontogenic too. And so this is the one we talked about below the canal. It's a well-defined radiolucency, specifically in that submandibular region. Once you've seen enough of these, they're pretty easily identifiable. In most cases though, you're going to recognize these. You're going to say it's a Stafne defect. Maybe you send for a radiologist just to get a second opinion, and then just monitor it over time. Now we have our lateral periodontal cyst, sometimes called the gingival cyst of the adult, although I would reserve that for when it's more of a peripheral lesion and so you start to see it through the gums. These are the same process though. It's a lateral periodontal cyst. Sometimes it's more central and so you don't see it clinically. And these arise from epithelia rests in the periodontium lateral to the root of a vital tooth, so that's important because you could have a cyst or a periapical lesion that's lateral to a tooth. And so keep that in mind. Periapical inflammatory lesions are not always the apices of teeth. Sometimes they're lateral because we have lateral canals. But in this case, it's not related to a non-vital tooth, and so that's why we have this highlighted here. Typically, they're unicystic. They're small and round, usually about 5 millimeters in diameter like this. But there is a variant of it called the botryoid odontogenic cyst, which is just a form of lateral periodontal cyst that forms these grape-like clusters. Looks like a small cluster of grapes. Very multilocular, but it didn't make it to our macho acronym, so we're talking about it now. And these occur over a large age range. That again, you'll notice a theme in these lectures that a lot of these things you differentiate more by location than you do by age, because they can occur over a large patient population. More than half of them are going to be in the mandible, from the lateral incisor to second premolar. If you notice this diagram, about 66% of them are on the mandibular premolars, or somewhere around there, maybe in the mandibular anterior. Occasionally the maxillary premolar, but it's much less often in these posterior locations, less often in the anterior maxilla. In some cases, it can efface the lamina dura of an adjacent root, and then it can look just like a lateral periapical cyst or a lateral radicular cyst. So in that case, the vitality testing is going to do a lot to help you out. This is the typical location, the typical appearance. I said about 5 millimeters, very round, corticated, but sometimes they can grow more extensively. This is more a rare one in the anterior maxilla, And this looks like an OKC. If I looked at just this lesion, this axial slice, it has well-defined cortication. It's expanding in more of that banana-shaped pattern. Everything about that says OKC, but just remember that lateral periodontal should be on your differential in some cases. And in fact, there used to be a tumor or a cyst that they would call a globulomaxillary cyst that they saw arise a lot of times, usually between the maxillary incisor and canine, so the lateral incisor and canine. But what they did is they searched all the literature and they found that those were variants, either lateral periodontal cysts, like we're talking about now, or OKCs, or lateral radicular cysts. That made up all of what used to be the globulomaxillary cysts, and so those don't exist anymore. And so that may be a presentation of it. Here in this one, the first thing that comes to my mind looking at this is it looks like a CG, but not the right patient population, so I should go to glandular odontogenic cyst. That's what that looks like in this case. But this was just a periodontal cyst, a lateral periodontal cyst that kept growing. And so in some cases it does look like that GOC. If you remember, that was kind of a rare one. Maybe you've forgotten that by now. But glandular odontogenic cyst is written all over that one. That's the image I want you to have in mind as the more prototypical lateral periodontal cyst. Just know that they can grow larger. All right, this one, that's the right location. Remember, this is our location lecture, so that tells you a lot. You see the mandibular premolar, you should start thinking, is it a lateral periodontal cyst? Is there a reason this could be a lateral radicular cyst, meaning an inflammatory cyst from one of these teeth? I don't see caries, I don't see fracture. Let's say the patient doesn't report a history of trauma, then that might be lower on the list, and you'll have lateral periodontal first. Here's one that's expanding, and it's pushing out the roots. It looks like both of these teeth have had endodontic access. Do you remember the one that I told you tends to expand the root in a triangular pattern like this? I think we talked about it more in the maxilla, but that was the squamous odontogenic tumor. So in this case, it looks like that, and that might be first on the differential. But again, it's that location, mandibular premolars here, and it's very cyst-like, very round. And that's what's telling you lateral periodontal cyst should be on the differential. So as you saw, it can be really similar to some of these other entities. I think we kind of covered most of these already. Management then is going to be simple excisional biopsy, simple enucleation. They don't tend to recur, just like most cysts, right? Very easy to manage relatively, right? So hopefully you can answer this fairly easy now. What's the most common location and appearance of a lateral periodontal cyst? Mandibular premolars, small, round, well-defined, about 5 millimeters. That should be the picture you have in mind. And just a deep thought for you. That's good advice brought to you free by Dr. Meekum. And now we get on to benign neural tumors. What do you need to know about these? Basically, you kind of know what you need to know already from our Principles of Interpretation lecture, where I said if you see a well-defined round thing expanding from the canal, think what? What are the tissues that occur in a canal? Either vascular or neural. So you think either benign vascular lesion or benign neural lesion, and these all look the same. There may be a little bit of differences that we'll talk about, but as long as you can identify that looks like a potential neural tumor, then at least you're barking up the right tree. All right, a schwannoma, which is sometimes called a neurolemoma, a tumor of neuroectodermal origin arising from Schwann cells, which is how it gets its name. Any age, but most commonly somewhat young, second and third decades, so teens to 20s. It's rare, but it can cause pain. As you see this 10-to-1 in the mandible, very high propensity toward the mandible, expanding the inferior canal, usually within the mandibular body, sometimes in the ramus. So just like I said, you already know what you need to know about these. Some expansion from inside the canal, you should start thinking schwannoma or benign neural tumor. Here's some examples. Look at that expansion. Very elongated expansion, but look at the canal. You ever pay attention to the canal and sometimes there's this loop where the metal foramen comes out back here? And so this is widening the canal, but it's maintaining that overall structure of the canal, where it goes down the body and then kind of loops around to the metal foramen. So this is a fairly large neurolemoma. This one's interesting. Maybe the first thing to come to your head wouldn't be a neurolemoma because it looks more multilocular. And so that's just kind of showing that there are variants of it. It can appear multilocular in some cases, but look how it communicates with the canal. And I think seeing that, I might be thinking a benign vascular or potentially neural thing. And so as I just pointed out, a lot of times hemangioma is going to be on the same differential. And so if you suspect hemangioma, what does that do to your treatment? You got to think about aspirating first, right? Because these can bleed. When these do occur in the canal, a lot of times it's more of a serpiginous shape. But like I said, radiographically, you're not going to be able to distinguish between the two necessarily. Malignant lesions, I said they follow the paths of least resistance. So similar to what they do in PDL space, it may extend through one of the inferior alveolar canals or any neurovascular canal. But the way it does is it is more of that irregular fashion, kind of destroying the cortical borders instead of just widening the cortical borders. And so those to me look quite a bit different, but maybe you'd have both on the differential if you're not sure. Is this really corticated or is it more irregular? In management, these don't tend to recur, but they're coming from a nerve, so a lot of cases that nerve might not be able to be preserved. So obviously that's going to have some effects on the patient in the future. And since we just talked about schwannomas, here's a fun radiology cartoon about a schwannoma. And now we're on to neuroma, which sounds a lot like neurolemoma. And so these can appear just like a neurolemoma, a schwannoma. But in most cases, this is more something that was caused by trauma, severed nerve fibers attempting to regenerate with the normal proliferation. And so the classic appearance of this is someone with dentures and they've got a lot of bone resorption. So a lot of disused resorption in the mandible until the mental foramen becomes exposed, and that irritates the nerves. And this is why it causes a lot of severe pain. But then it starts to grow from there, and typically you're going to see it enlarge the mental foramen. So that's kind of the classic appearance when a dentist is going to find a neuroma. But in other cases, it's going to be somewhere along the canal and look just like a neurolemoma, so you can't really differentiate them. Treatment about the same, simple excision, recurrence is going to be rare. Now on to neurofibroma, and we already talked about neurofibromatosis, so you kind of know what these look like. And there's just kind of some technical differences with how it incorporates axons, which is different from a schwannoma, which displaced them. It's going to be really similar to a schwannoma. These typically occur more in the young patients. And so everything else you notice about this is just like your schwannoma, so it may be impossible to differentiate. Same management, excision, seldomly recur. So some examples of that. Everything about this looks just like your schwannoma, right? And so radiographically, we can't tell the difference. This one, though, it looks more serpentine. Maybe first on the differential, I would have a hemangioma, but think, yeah, it could be a benign neurotumor as well. All right, buccal bifurcation cyst, or if you're fans of BBC, that's the acronym for this. Sometimes called mandibular infected cyst. A lot of times it has infected or inflammatory in the name because a lot of times these are infected. Not because the tooth is non-vital. This is not a periapical inflammatory lesion. In fact, the teeth are vital in cases of BBCs, but it's because they typically communicate with the oral environment, and anything that communicates with the oral environment then is exposed to bacteria. So you can see this sclerotic bone around it. You can see signs of inflammation. These typically happen in younger patients, so you see age less than 20. It's as these teeth are developing and they're starting to erupt. Sometimes it delays eruption of that molar. And here's a key thing I wanted to highlight, buccal tilting of the crown, because it occurs right in the furcation of that root, and then it grows inferiorly and it pushes the root inward. So if it pushes the root inward, the crown kind of tilts outward. And that's a key thing that I've used in a lot of cases to identify these, where it really differentiated them from other types of lesions. So I think that one's interesting. Can't really see that in this case, so it doesn't always happen, but when you do see it, it's a big sign. Here we see it. A lot of times these will occur bilaterally because they're developmental. And so these teeth develop the same. If one's susceptible to developing one, the other one is going to be susceptible as well. And so it develops here, it pushes the crowns inward. You see what I mean by buccal tilting of the teeth? See how much separation there is between the buccal and lingual cusps? So because the roots tilt inward, the crown tilts outward. And so the buccal cusps get projected more inferiorly and the lingual cusps more superiorly. And so you see that separation on both sides in this case. Here we have an occlusal view showing the same case. So we can really see it's something that arose on the buccal surfaces of these molars. I didn't say specifically which ones. Usually it's mandibular molars first in most cases, but sometimes second. All right, occlusal views here. Notice the lingual tipping of the roots, and so the kind of coronal tipping of the crown. One thing that sets it about. What else do you notice?
What are you doing in my swamp?
There he is. So if you saw that and right away thought Shrek, then good for you. You recognize the infection. We have an inflammatory cyst, there's infection, there's a periosteal reaction. If you didn't see my other videos, the reason you thought of Shrek is because this periosteal reaction is an onion skin reaction, and Shrek tells Donkey that ogres are like onions. So there you go. You should always think of that. Always think of osteomyelitis when you see the periosteal reaction, at least when you see the laminar periosteal reaction. And so differential, or let's just think about this. What would you mistake for buccal bifurcation cyst? I mean, it could be a periapical inflammatory lesion, right? And so vitality test the tooth. It could be an OKC. If you see it on both sides, which sometimes we see with BBCs, you might be thinking, what? Basal cell nevoid disease. Probably not cherubism. That's when that is younger and further posterior to the teeth. And so that's why a lot of times I look for that classic tilting of the teeth. This does mention Langerhans histiocytosis. I feel like buccal bifurcation cysts, more often they're well-defined corticated because they are a true cyst. Whereas Langerhans usually doesn't have that nice corticated outline. You can tell it's more of a destructive thing. But pay attention to that characteristic tipping of the crown. All right, removal should be conservative. So most cysts, right, if it is a true cyst, removal should be managed well with just conservative curettage. You don't necessarily have to remove the root, and they don't tend to recur. So that's nice. Another deep thought for you here. I found this to be true in my life. Doctors say that jogging might add years to your life. Yeah, I ran for a few months and I already felt 10 years older. All right, now these ones I'll go through quickly. I'm kind of covering these just for sake of being thorough. Not my favorite ones because they don't typically occur on radiographs, but we do need to talk about them a little bit here. So, nasolabial cyst. This is a rare cyst that arises from epithelium entrapped upon the embryonic line of fusion of maxillary medial nasal lateral nasal processes. Usually it's right in this nasolabial fold, or it could arise from nasolacrimal duct epithelium. So think of just this soft tissue swelling lateral to the midline. You don't have a dental cause, right? Someone may go to the dentist when they see the swelling. They may think they have a tooth infection. But you take radiographs, you don't really see anything. It may be a nasolabial cyst. In some cases, though, you'll see it erode into bone. And so look for cyst-like features if that happens. And it should be a very benign corticated entity. So case in point here, we have an axial CT. Patient had a little bit of swelling in that nasolabial fold, and this definitely looks like something that arises in the soft tissue, doesn't it? Just looking at the epicenter of that lesion, and then it's eroding. It's causing a well-defined smooth border. And here we see an occlusal radiograph of a nasolabial cyst. And what do you notice? It maintains that corticated border. It's coming from the outside, but it's pushing in. And so it can be a little bit destructive, just like any benign thing, but as it does, it's more slow growing and it maintains that cortex. So here it's pressing into the nasal cavity, raising the floor of the nasal fossa. And then here's another one, the thyroglossal duct cyst. And this arises from epithelial remnants of the thyroglossal duct, which is something that extends from the foramen cecum, which is in the midline of the dorsal tongue, down to the isthmus of the thyroid. So it can be anywhere along that line. Think of the top back part of the tongue, all the way down to the thyroid cartilage. And this is actually the most common congenital cyst and midline mass of the head and neck. And so if you see a midline mass in the soft tissues, this should definitely be on your differential. And so this is developmental. It should be detected before the second decade. And so we said it could arise anywhere from the foramen cecum, but typically it's a little bit lower. Typically it arises somewhere below the hyoid bone, although it could arise in the tongue. And what's the big keyword here? Remember, location is everything. Midline of the neck, soft tissue growth. In a young patient, think thyroglossal duct cyst. And then this one is off-center. Think somewhere around the sternocleidomastoid. This is the branchial cleft cyst derived from remnants of the first through the fourth fetal branchial arches. So most common in the second and third decade, so this does arise a little bit later. It'll be anterior or maybe deep to the sternocleidomastoid and a slow-growing, painless, fluctuant swelling, just like any of these soft tissue ones we're talking about. Rarely is it going to be bilateral, but that can happen. And so the pairing to remember is midline for thyroglossal, lateral neck for branchial cleft. And then dermoid cyst. This is a teratoma derived from trapped totipotent blastomeres. And that just means it has cells that can eventually differentiate and become a lot of different types of tissues, including keratin, sebaceous material, bone, teeth, muscle. You ever heard of the person with a tumor that grew teeth in his brain? That was a similar thing, a teratoma. So usually in the teenage years, maybe up to 25, and really only a small percentage of these develop in the mouth. And when they do, it's in the floor of the mouth, or in some cases the tongue, where they can interfere with breathing, swallowing, speaking, and eating. Going to be fluctuant and doughy to palpation in most cases. On imaging, it's going to be well defined and uniform. Typically, it'll have a fluid attenuation. So if you're looking at a CT, it'll be hypodense. If you're looking at MRI, it might be bright on T2. And then in some cases, just like with the nasolabial cyst, it could erode into underlying bone. Your differential, we don't talk about that in this course, but you should know what a ranula is. And that's a fluid-filled cyst-like entity caused by obstruction of a salivary gland. For ranula specifically, it's the sublingual gland, and it's when saliva accumulates in this cyst in the floor of the mouth. And so obviously dermoid cysts on the floor of the mouth, that should belong in a differential with the ranula, also cystic hygroma. And then this one we just covered, we said midline neck, think thyroglossal duct cyst. Here's imaging of that. If you don't appreciate CTs yet, this is very low density, and you're probably not used to looking at these very bright things. This is a T2 MRI, and fluid appears very bright on T2 MRI, and that's telling you that these are definitely something filled with fluid. So think something cystic, and we just went over these cysts based on location. What's that one? This is the hyoid bone. Hopefully you can appreciate that as a dentist. You know your anatomy. And it's roughly in the midline, a little bit off center of the midline. But what was the midline one in the neck? Anywhere from the foramen cecum to the thyroid isthmus. That was your thyroglossal duct cyst. And then this one is off center, so it's lateral to the airway. Just for comparison, we have the submandibular gland right here. In this case, it's kind of squished over here to the middle. And so what did we say more in the lateral neck? That's your branchial cleft cyst. And this one, it's, compared to the other ones, relatively small, but still very sac-like, very fluid-filled. And this is the masseter, and so we have the parotid gland. This is a cyst-like thing right in the middle of the parotid gland, and we talked about this in the salivary gland lecture. This is a lymphoepithelial cyst. So this is a little bit further up than the branchial cleft cyst, more in kind of the facial tissues, just behind the masseter and right in the parotid gland. How about this one? Hopefully you recognize where that is. Do you appreciate that these are teeth? This is a mandible. This was a maxilla. Hopefully you can recognize the shape of the teeth. Even if you don't know what MRIs look like, when it has the teeth in it, I would expect as a dentist, you're able to recognize what you're looking at. And so this is the floor of the mouth, well-defined, fluid-filled, sac-like thing. And what did we say? It could be a ranula, or it could be a, what did we just cover? Dermoid cyst. All right, swelling under the tongue. What was the differential? I kind of already went through this. Ranula, dermoid cyst. What's the midline one that we just talked about? Thyroglossal duct cyst. In which direction does a BBC, the buccal bifurcation cyst, tend to tilt the associated mandibular molar? Well, the roots tilt lingually and the crown tilts outward or buccally. This one, just by the location and appearance, you should be able to nail that right away. You should look at that and say, boom, Stafne defect. Not much else to be said about that. I just thought this was a cool picture of the earth when we're talking about location and how identifying where things are is so important. And so yeah, each of those things, keep in mind, focus on the radiographic appearance that we talked about, those things that really stand out based on location, and you should do well. That's going to bode well for you for the rest of your career, I think. And then I was talking about Chipotle, Cafe Rio, also looking up a picture of a burrito and got really hungry. I think I'm going to print off a little flyer like this and put it on my window, but change it to, we'll trade radiographic evaluation for burrito. So when you come to my office, bring a burrito. Just kidding, don't do that. All right, bye.